Across all demographics, clinical risk outweighed radiation risk by at least 400% in some groups and some much more. When I first saw that number, I was taken back. I was pretty shocked. It seemed high.
Welcome to Frame by Frame, Rethink Imaging, a podcast by Imalogics. Here, we explore the intricate world of medical imaging, aiming to dissect the field and inspire both professionals and curious minds alike. I'm your host, Chris St. John.
Hi, everyone, and welcome back to Rethink Imaging. Today, we are joined by Francesco Ria, PhD, and he's a medical physicist and imaging scientist at Duke University, where he works with the Carl E. Ravin Advanced Imaging Labs and the Center for Virtual Imaging Trials. His research focuses on CT optimization, radiation risk, and diagnostic performance, with particular emphasis on how imaging decisions impact real patient outcomes. Dr. Ria is known for challenging the assumption that lowering radiation dose automatically means safer care, and for developing quantitative frameworks that balance radiation risk against the clinical risk of missed or delayed diagnoses. He is the lead author of a recent communications medicine paper proposing a total risk approach to CT optimization, reframing imaging safety around patient outcomes rather than just dose alone. Welcome, Dr. Ria. Thank you for being here.
Hi, thank you for the invitation. It's really a pleasure to be here.
I'm super excited to talk to you today. Without sharing too much, someone close to me recently had a health scare, and we went through a bunch of imaging recently, multiple head CTs, MRCT, and I found myself thinking about you because, as the person there in the ER supporting them getting a head CT, all I could think was, turn up the dose. I want a higher dose.
Okay. All right. That sounds like the battle I have with my daughter because I like loud music and she doesn't. So,
okay. It was just funny. So for decades, CT optimization has been, very much about lowering radiation dose. And in this recent paper, you write that optimization has been one-sided and strongly biased towards radiation risk only. And I'm curious, what was the moment or the realization that made you question whether that focus was actually protecting patients?
Yeah, thank you for the question. That's really interesting. And also made me think a little bit of the last few years. I don't think there was a moment when we realized this. I always use the plural we because it is a team effort. I think that before we start thinking outside the box, we need to realize that there is a box. And so there was some sort of discomfort that I always felt together with my coworkers, because there is always this apologetic interaction with other medical professionals, with patients. I'm sorry, we are hurting too much, we're giving you dose, etc. But then we are part of medicine. And in medicine, we are not allowed to do anything if we are not doing more good than harm. So how does radiology fit into the medicine framework if we are only talking about risk? And we know that what we are doing is helpful, is useful. All the other medical specialties ask diagnostic imaging to provide essential information for the patient, for the diagnosis. So there is something good that we are doing, but we are never able to put a number on it. And so we just decided to give it a try.
Yeah. And so, radiation risk dominates how everyone is thinking about CT safety. And I believe you call that dominance contrary to common assumption. Why do you think that radiation fear became so central in the imaging culture compared to diagnostic accuracy or patient outcomes?
Okay. Allow me to make a little digression. I come from a small town, and it's very easy to be called with some names, the people give you nicknames for everything. I don't want to pass like the guy that advocate for a high dose. I want to be the guy that advocate for the right dose.
Right.
That's what we are trying to do. And sometimes it's higher, sometimes it's lower. So I think that the fear of radiation comes from a real fear. It's something that we cannot see, we cannot smell, we cannot touch, but it's still harmful. And can be harnessed to build bombs and can be harnessed to cure tumors, with radiation therapy. And then there is a whole Hollywood and comics, and they always use this concept of radiation to give superpowers, to give mutations, whatever. So it's easy to be afraid of something that we don't really know. But also I think that in our field, because we use them every day, there is some sort of legacy. In the past, traditional CT or radiography or mammography usually the relationship between radiation dose, radiation exposure, and the quality of the image was pretty straightforward, because I increased the dose and I got better images, because the system, like, it was manual. I have to select what kind of current or tension I want to use, and the outcome was, decided by the operator. Right now, there are a lot of automatic systems implemented in the machine, so we don't know. We lost this traditional relationship. So it doesn't make sense anymore to talk only about dose, because that's just part of the equation. But for the same dose, for different patients, we can get to different image qualities. And so say this dose is higher or lower doesn't really tell us much about the overall procedure.
And so you point out that, we built all these models for radiation risk, and there's been, quote, a paucity of studies assessing clinical risk. Practically speaking, what risks were we not seeing before you started, this quantification work?
Yeah, every word that we wrote in that paper, and it was carefully weighted. So first of all, we decided to follow this clinical risk approach because there was a need to compare apple with apple. So let's make an example, let's talk about surgery. We know that a surgery procedure is justified if the risk of dying without getting the surgery procedure it's higher than the risk of dying during the procedure. So even risk to benefit needs to be characterized in terms of risk to risk. That's the way that we can compare apple to apple. So we decide to do the same in radiology, and we say, okay, what is the benefit of radiology, the effective diagnosis? Therefore, what is the risk associated with the misdiagnosis? And that's what we are trying to compare with the radiation risk. This is just only one risk that we are adding into the traditional narrative that was based only on radiation risk, but there are other risks that we can incorporate in the future. I'm thinking about the risk of contrast media. Is there half of our exam CT are performed with contrast media? And it would be nice to put some numbers there also to see how many adverse events we have, what is the kind of dose that can be tolerated, can we optimize the dose? And then there are other risks that, every other medical procedure, every other medical specialties also include, and this risk can be associated with the history of the patient. Even investigating the same pathology, if the history of the story of the patient is different, can have different kind of risk. So definitely, once that we got outside the box that I mentioned at the beginning, and we say, okay, radiation risk is only one part of what we are trying to quantify, then of course, there are a lot of other risks that we can try to incorporate in this model.
Yeah, it's so interesting to me that the risk-to-risk comparison is such a subversion of even of the language that we use societally to talk about risk in general, right? We are constantly saying risk-benefit, risk-benefit, risk-benefit. I don't think at any point until, at RSNA, when I heard your talk, was I actually hearing anybody talk about risk to risk?
You can apply this to every kind of human activities, I drive every day from my home to work, and there is a risk of getting in a car accident. So I can reduce the speed and the risk reduces, but probably the risk of being late to my meeting and getting my boss upset increases, there is always a risk to risk comparison. So do I want to take the risk of spend 5 hours in the car to make 2 miles, or do I want to take the risk of speeding a little bit more? It's always a risk to risk in everything we do, even the lottery. They sell the lottery to us oh, you invest $1, you can win $1 billion, but really they should tell us that we should compare the risk of investing $1 with the risk of not winning, which is much higher than the percentage of winning. So everything can be framed in this way, and probably it's more understandable because, again, we are comparing apple with apple, the same units.
Yeah, for sure. But yeah, we just we that's not the way I think that we have just, grown and learned to think about it. So I love this reframing of benefit as risk, specifically defining the clinical risk as harm from misdiagnosis or non-diagnosis. So was it important to put radiation risk and clinical risk into the same units instead of comparing dose to image quality or other detection metrics?
This depends on what we are trying to do. So if we are trying to see the performance, to measure the performance of the scanner, then we can use traditional metric. We can get a phantom, measure the CTDI volume. You tell me if I'm using words that the audience might not like, but we can take a phantom, measure a measure an exposure.
I think we can all get behind phantom and CT eyeball on this podcast.
Okay, perfect. Because we physicists are quite of nerds, so sometimes we like nomenclature very much, too much. So we can get a phantom and we can measure the exposure in the phantom, we can measure the image quality, and perfect. I can assess how the scanner it's working, but patients are not phantom. So the CTDI for the patient is not enough because the same CTDI to different organs is related to different risks. So the same image quality can bring to different diagnostic readings. And we saw it, for instance, now in photon counting, which is the topic of the hour. So the main concern with photon counting is that the noise magnitude of the images is very high. But there are some tasks, like in thorax exam, in the chest, for instance, where the resolution is so high and that even this extra noise doesn't really bother the radiologists. The radiologists are very happy, while the same noise can be a problem in other anatomical regions. So measure the image quality without talking about the task that we are investigating is not enough. It's just, it is good to assess the performance of the scanner, but again, patients are not phantoms and pathologists are not inserting a phantom. Like, everybody is different, and we should take this into consideration.
Forgive my naivete here, but so what you're saying is, like, different scans, like a head CT versus an abdomen pelvis or something, different noise thresholds are going to be different in order for those images to be readable.
Yes, I mean, yeah, different tasks. Yeah, it depends on what you're trying to see. I mean, again, we can ask the radiologist about this, but trying to investigate kidney stones, it does not require this kind of fancy images, because I mean, it's a piece of rock into the human body, so we should be able to see it, even if the images are not perfect. But if we are trying to detect a subtle lesion in the liver, then we really need like a lower noise or other kind of image quality feature. It depends on what we are trying to investigate, and this is also something that we cannot stress enough. So many times I read paper and say, oh yeah, we reduced the CTDI, therefore patient safety increased. That I don't know. Maybe yes, but I don't know, because I don't know where to give the CTDI, to the head, to the chest, to the abdomen. I don't know what kind of organs were exposed. I don't know the age of the patient. Like, if we don't contextualize this kind of analysis, again, we cannot draw conclusions that make sense.
Yeah, absolutely. I mean, like, not to tie back to my personal story, but like after the second head CT and they continued to say everything that looked fine, I'm like, it's a head. Crank it up. Like, I'm not on here trying to preach to the world that we need to crank up our doses, but just, it's very top of mind right now, right?
Yeah.
And so
it brings me, since you are bringing me an example, this conversation is bringing me a story from a few years ago. I think it was like 2015, 16. We did a study within Duke University and my previous Italian institution, CDI from Milan. And we asked the patient what they know about radiation dose. It was the topic of the hour at the time. And then I have no idea why, but we put this question into this survey. We asked the patient, do you prefer having the radiation dose of your exam reduced or the image quality improved? It was like very straightforward question, like no context whatsoever. Just tell us. There were like 700 patients. It was a significant amount of patients. They split almost 50-50. They were like 45-55, I think. So patients understand this issue that we are facing every day. And if they are coming to the hospital because they want answers, the same way that if they are sick and they are taking an antibiotics, they want the right dose of antibiotics. They don't want too much, they don't want too low. They want a dose that is safe and is effective. That's what we should try. So we should give a radiation dose. We should use a radiation dose that is safe for the patient, but at the same time, it allows us to answer to the question, the clinical question that we're investigating.
Yeah. Okay. Well, I might be getting myself a little bit into the weeds here, but
please,
I want to keep moving. So in your model, total risk, I believe, is literally just radiation risk plus clinical risk, which sounds surface level quite simple, but the inputs going into that are really not, right? You have disease prevalence and false positives, the AUC, the area under curve, life expectancy loss. I'm curious about, how those different variables surprised you and how you saw them, affecting total risk.
Well, the thing that we never considered before, it was the ethnicity, the ethnic group, the race. And people from Europe will forgive me, race is not it's a sort of a bad word in Europe and United States. I mean, it's medically appropriate. But that was something that we never considered. But because the side effect, the adverse event associated with radiation is usually induced cancers, and different ethnicity, different races have different incidence of cancer, but also different survival for cancer. So if even when we're just trying to talk about radiation risk only, we need to incorporate this demographic and this ethnic and race information into our model. So this was the thing that we never considered before. That was, to us, it was like, I don't know, interesting. Because we knew that AUC is basically how good the radiologist can read an image, and we knew that life expectancy is well. But I mean, incorporating not just the age and the sex, but also the race of the patient was something that surprised us a little bit here.
Yeah, and this follow-up may be like a little bit delayed here, but just still talking about, like the reframing to benefits back to risk. I'm just kind of curious, there's a piece of it that feels very mathematical, obviously, like this is what your paper is about, this quantification, but there's also like a mindset shift that needs to be happening as well, correct? Yeah. Or I guess how do you balance those two, like math versus mindset?
That's a great question. It's a great question because we are physicists, that we are men of science, at least with a science background, and we work in medicine that is mostly an art, Mm-hmm. So we need to try. But yeah, we knew already that something has to be done in terms of switching our focus. I think the mathematics provided the language to communicate this new model. Because I can go to people and say, listen, you need to change the dose or to increase the dose, reduce the dose, but they want to know why. And I can tell them, oh, listen, you're going to see the image better or the image worse. That's fine, but it's still qualitative. It's based on preference, it's based on experience. Right. But if we have some numbers that we can show, I think that's really what we need to support this shift in the mindset that you talked about. And let me tell you something. When we showed the results of our preliminary studies, still simulation, to the radiologists, they are quite happy because they say, yes, we know that we are doing good things for the patient. Thank you for showing us how much good we are doing, instead. And so it's I don't know, it's an optimistic message that we are trying to broadcast as well.
Yeah. And so you simulated 1 million digital patients undergoing abdominal CT for liver cancer.
Yeah.
I'm curious why y'all went with liver cancer and why, such a large simulated population was, well, I mean, the bigger the sample size, the better. But, why liver cancer and why this specific population size?
I would say that the main reason is because at the beginning we had a small data set of liver cancer patients that were acquired with several doses. So it was easy to start. No researcher will ever say that that's the reason why we do some studies, but sometimes we have to use whatever we have in our home.
Hey, you take the win, right?
Exactly. So yeah, we had this small data set of patients with different doses, and so I started looking at these things here. And then we realized that, liver cancer is the third cause of cancer in the United States and in the world, so it's very timely. It is also hard to diagnose because liver is soft tissues and the lesion usually are very subtle. So it's a good task to measure this, to try to test this model. And then there are a lot of data in the literature, in the National Cancer Institute. They have a lot of data about mortality, about incidence, about survival. So it was a safe first step. But of course, the mathematical equation is the same. We can apply the same model to every kind of task that we want. We just need to change the parameters. But yes, liver cancer was like a safest and also a very impactful pathology to investigate for several reasons. Why 1 million? It's a round number.
Yeah.
But also if you start thinking, we need to simulate different radiation exposure condition. So we went from 0 to 50 milligray of CTDI just to include everything. We needed all the ages from 0 to 100. We need male and female. We need 4 different ethnicities. If you start putting all this combination or permutation together, you get a big number. So yeah, 1 million was a safe number to show some robust results.
Yeah, and how do you even, what is it even, I understand that you simulated digital patients, but what does that actually look like in practice?
A spreadsheet.
Girl, yeah, great.
No, I'm kidding. Yeah, several spreadsheets. No, yeah, how does it look in practice? It looks like a statistician and physicists working together to try to put all these variables into some kind of software and making this software to work, and then spit out some data. So there are, like every computer things, we have some inputs that are the age of the patient, the sex, the ethnicity, the presence of cancer or not, whatever, and then we have some output at the end. But yes, it's mostly computer-based at this level. Informed by clinical practice, of course, because, I mean, we put them number that makes sense. We work with the radiologists as well.
Let's dig into, your results a little bit, right? So across all demographics, clinical risk outweighed radiation risk by, am I correct that it is at least 400% in some groups and some much more?
Some groups, yes. Mm-hmm.
I mean, when I first saw that number, I was taken back. I was pretty shocked. It seemed high, but was that something you expected, or was it surprising to you as well?
No, it wasn't surprising. First of all, then this is a simulation. So, I mean, these are not absolute numbers. We need to go to test into the clinical patient, but I mean, the math is robust. Again, I don't know why we treat radiology differently than any other medical specialty. FDA approves drugs and medical devices based on safety and effectiveness. If we are doing something in radiology, it means that we are doing more good than harm. So we were expecting already that the clinical risk outweighed the radiation risk, for sure. Otherwise, I mean, I don't know what we're doing here. It's not as. So this was expected. Yes, you're right. Seeing it in a curve, in a plot, it was something fun to see.
Yeah.
For the first time. I don't want to lie. It was fun, but also that's what we were hoping for. And again, we think that that's what we are doing in practice.
Yeah, I mean, and it's
sorry, I don't have anything exciting to add. I don't have anything exciting to add, but
I mean, that's exciting enough for me. Yeah. Nothing excites me like spreadsheets and percentages. Let me tell you.
Right, perfect.
So obviously, clinicians are not a monolith, right? Everybody has different opinions. Like there's lots of opinions about dose and cumulative dose and this and that. And, everybody's constantly having these internal conversations. But would you expect many clinicians out there to really have an understanding of what that ratio could possibly be? I mean, now they're going to have access to this paper and stuff, but I'm curious what you think, your average clinician might expect this to look like. When you don't have to answer for them because you're not them, but I figured
I'm not a clinician. I don't want to ask for MDs, but again, I'm pretty sure that there is a common consensus about it. I spoke with gastroenterologists, for instance, about this AIM project, and we thought that this model was so cool, and we spoke with the gastroenterologist, say, oh, this is quite simplistic, because when I ask for a radiology exam, I'm considering the patient history, the patient background. I go back to generations, they put a lot of consideration into it. But still, they know that when they are asking an exam or a procedure in general, is something that is going to be beneficial for the patient. So I'm pretty sure that there is there is for sure a common understanding that the clinical benefit outweighs the risk. It's also in radiology, not just another medical specialty. But again, if I can piggyback a little bit on your question, I think that there is a little bit of overemphasis probably in radiation risk in our field. So recently we presented our this study. So for fun, we went to look what is the mortality risk from surgery. And it is a little bit above 1%, which is reasonable. Then we look at the most pessimistic study in radiology, and we saw that the risk of having an induced cancer, not dying, but having a cancer in radiology, even with the most pessimistic model, is 0.04, so 30 times smaller. Then we went into the literature and we say, okay, how many papers last year talked about radiation-induced cancer? 35. How many papers talk about surgery mortality? 1. So let me say it again. Surgery mortality is 30 times higher than radiation-induced cancer, and they talk about surgery mortality 30 times less than in radiology. I think that we are being over-apologetic, probably, and I I mean, it's always good. It's better saying the story, of course. But I mean, let's just don't get depressed.
Well, yeah, I mean, and
let's just don't get sad,
that is the nature of the press, right?
Yeah.
It is much, it's much more financially viable to publish stories about things that scare people than to publish a story that says, like, you're probably fine if you get a CT. Like, who's going to, like, how do you turn that into clickbait, right? How do you drive ad money from saying, like, getting a CT is probably okay?
Yeah. And I mean, when we say at the beginning that it is a legacy to talk a lot about radiation dose, it is really a legacy because the regulations always push towards radiation dose monitoring. How many radiation dose monitoring softwares we have in the market? Dozens. How many image quality monitoring software we have? 2 or 3, I think. So there is really, a mismatch, a disconnect between these two things. But I don't see any other medical specialties having sessions about reducing the risk of dying. I don't go to a surgery conference and they have sessions about, they reduce the risk. I mean, that's the goal of everybody, but they are not so exclusively focused on these.
Yeah. All right. Well, so, I mean, like, let's build on that, right? So, in your results, radiation risk averaged about 0.009 deaths per 100 patients, right? While clinical risk averaged 0.045. So how should we interpret that difference in real world terms? And what does that actually mean for, a patient sitting in a scanner?
Yeah. Do you want politically correct answers? Do you want the real answer?
Obviously, I want the real answer, but if we got maybe start correct and then get into the truth.
Yeah, I mean, if I'm writing a grant and say, this paved the road toward the personalization of care and therefore toward the minimization of risk, whatever, that's what we always said. The real answer is we don't know what it means for the patient.
Yeah, that's fair.
Because all the theory, all the medicine is based on experience, on population. I have no idea what's going to happen to the single patient, And a patient need a knee prosthesis, and the doctor say, okay, fine, you do this surgery and you're going to be fine. And then after 2 months, the patient go back and say, listen, I cannot work. And the surgeon say, yes, there are complications. A complication is a fancy word that we use in medicine for the unknown. We don't know, like even a drug is approved for marketing, but the clinical trial never ends. There is phase 4 of the clinical trial, which is post-marketing surveillance. What does it mean? It means that every patient that is taking that drug can react differently, even if we have years of data of millions of patients that use these drugs. Human bodies are different, so we have no idea what's going to happen to it, but we can learn from experience. I know that ibuprofen is effective 99% of the time, and I want to get a drug that is effective 99% of the time, instead of a drug that is effective 50% of the time, So what we try to show with this 1 million simulation things is that for the general population, again, it's better to focus on improving the quality of the image. It's better to focus on improving the diagnosis, and it's better to focus on giving the radiologist better images.
Right.
For the single patient, I have no idea. But overall, and let me add a number that always blows my mind.
Yeah.
Life expectancy in the United States, but across the world, in the last 70 years, so the last time I checked, grew by, I think, like 13 years, something like that. So basically, every year, we are giving 2 more months of life expectancy. And that's, to me, it's impressive. Every year, we live 2 months longer. So what we are doing makes sense. Medicine makes sense. We are giving good results. We are advancing the care. We are advancing the life expectancy. So we are working in the right direction. Then, of course, human body are not machines. Even when I go to the car dealer and take my car, sometimes they make mistakes, and these are machines. So human body are a little bit more complicated, but we are definitely going the right direction.
Yeah. So one of the most counterintuitive findings is that in over 90% of cases, the CT dose that minimized total risk was actually higher than the dose patients are typically receiving. Let's talk about how, in some cases, increasing doses is often reducing overall harm.
Yeah. And again, I mean, I cannot stress this enough. This is liver cancer. This is simulation. For a broken wrist, this scenario will be different,
Of course.
Because, the images will look different. We don't need all these doses. So this is just the case of liver cancer, and these are simulation. Yes, we found out that for 90% of the cases, we can increase the dose and get overall risk that is lower for the patient. Now, in most of the case, the difference was mathematically perceivable. Like it was 10%, 5%, 6%. We can argue until tomorrow if it makes sense to increase the dose to reduce the risk by 5%. This is a topic for regulators. It's not a topic for, luckily,
Right.
it's not a topic that I need to answer. But yeah, the message that we are trying to broadcast is that there is room for optimization. Luckily, we are not alone in this because, for instance, ICRP in publication 135 a few years ago clearly stated that if radiation dose is low enough, image quality should be the main focus. And they wrote in the ICRP that optimization can result in an increasing of dose. Can. Again, I don't want to be the guy that advocates for higher dose. I want to advocate for the right dose. But like playing with radiation dose should not be a taboo. It's a tool that we have. I mean, we have this tool of looking inside a person without cutting the person open. Let's use it in a way that is effective and that makes sense.
Yeah. So, I mean, I'm glad you brought up the ICRP guidance.
Easy.
You know, that optimization sometimes includes increasing dose to preserve diagnostic information. Why do you think that nuance has been so hard to, take into a daily radiology practice?
Yeah, I think it's a lack of data, to be honest.
Mm-hmm.
When I came at Duke like over 10 years ago, I found out that they were already measuring image quality, at least noise magnitude in all the patients that underwent CT. And to me, it was mind-blowing because Duke was the only center in the world. And we are still leader in the world about image quality estimation. It's not easy, but luckily now with the new computer system, we can do this quite, no, I don't want to say easily, but in a way that without needing supercomputer. So yeah, there was this lack of data. And so we play with the data that we had. And radiation dose were this data because regulations require to monitor radiation dose. And so we try to use that. Also, remember what we said at the beginning, that in the past, radiation dose could be used to predict the image quality. So, there was some kind of legacy that we carry on with us. But again, once that we start seeing that the radiologist world is not unidimensional, but there are more dimensions, then of course we can try to how can I say, to personalize everything better. If you don't want to talk to personalize, at least we can talk about more task-specific optimization. Why do I need to use the same abdomen protocol for everything that is in the abdomen?
Right.
Again, we don't do that, but there is room to make more nuances or to create more task-specific protocol. Again, if I have a patient with cirrhosis of a specific ethnic group with some specific risk factors, I know that the risk of having liver cancer is higher. I want to be sure that I can see it. So perhaps I can be a little bit more aggressive. A child without any history, maybe I want to be more conservative. Again, we need to, and now we have the tools to do this. Like in the past, it was impossible. Now we have the informatics, we have the computer power, we have the information system that can really support this kind of decision making.
Yeah. Okay. Continuing on the regulation train, you explicitly reference recent regulatory pressure like CMS scrutiny of CT dose and suggest that an, quote, over-exaggerated and obsessive, end quote, focus on radiation could negatively impact patient safety.
Mm-hmm.
I'm curious, do you expect this message to actually land well with policymakers?
Maybe in a few years. And the way, the reason why I'm saying this is because regulation is always late,
Yeah.
So the moment regulation is something that we have, that we need to abide by, that we need to respect, that we need to do our tests to that. But the moment the regulation is approved, is already late. So if we respect the regulation, we are already 10 years late from there. I can think about dozens of examples of even the mammography rules or whatever. They were created when radiologists was a different beast. Like there wasn't artificial intelligence, there was automatic expert. Yeah, we respect the things because we have to respect that, but is it enough? Probably it's not enough. So regulation is one step towards, providing the best of care. The regulators, yes, I think that, we are doing this for every medical field. Again, FDA clearly says that, and all the regulatory agency, that a procedure should be approved or a drug should be approved based on safety and effectiveness. I would like to see this applied also to radiology. So I hope that the next set of rules will ask us to, in some way, to estimate the effectiveness of a radiological procedure.
Yeah, and I really like your point about like the delay of regulations, right? Like even if we just talk about the new CMS measure, right? Which like, we've seen in practice some people changing their approach based on this measure, right? There have been some good results of it. But at the same time, right, this whole measure is built around data that I believe is from 2014 is my memory, that like pre-photon counting, right? Like, so we're
Pre-machine learning.
We need to be able to keep up.
Yes. I think that also we should try to learn from our story. I don't want to say mistake because nobody makes mistake in purpose, but you analyze the story and you realize that you can do something different. So, of course, let's talk about radiation dose and then translate this to image quality and CMS. A couple of years ago, maybe 4 years ago, we published a study and we look how many radiation dose metrics we use in CT. We counted 11 radiation dose metrics that we use in CT. CTDI, DLP, SSD, organ dose, different way to calculate effective doses. And we found out that even effective dose, the same metrics calculated in different ways, can give us difference up to 200%. So what are we talking about here? I mean, we should try to establish methods that are standardized and consistent. I think the CMS, if they want to, that's the problem that they're having. That's why they are postponing, the implementation, because we don't know what kind of methods we need to use. But we should learn from our past and say, okay, this is the method, and now we can compare all the cities that we want, all the institutions that we want, all the vendors that we want. Otherwise, again, it's really difficult to make comparison that makes sense. And allow me to say, it's very easy to cheat. Because I can make a software that show that your noise is almost zero. I go measure the noise in some area, fine. Are we doing something good for the patient? Maybe I don't think so. So we want to be as specific as possible, I think, and try to create some standards that are also robust and based on the current technology. Because if we are implementing today something that is based on 2014, we are already 15 years late, and we need to use these things for the next 15, 20 years. So I wonder my students in 20 years from now, I say, okay, what were you doing 10 years ago when they implemented these things,
Yeah, and just the rate at which scanner technology is improving as well, right? It's just getting faster and better, and we have more and more tools to improve those machines. We're starting to climb vertically up an exponential curve here. So it's hard to stay on top of things. Let's start to wrap up here. So this framework allows optimization and justification to become, more patient-specific rather than just protocol-driven. So if this model were start to be implemented clinically, what starts to change first, right? The scanner, the protocol, or like the decisions made and the conversations to have them?
So first of all, I think that this would be, on the nerd side, this would be a great tool for improving the consistency. We always talk about improving consistency, but we want to be consistently good. And different scanners, because right now they're very sophisticated, they have a lot of automatic tools, etc. And we don't exactly know what happens when a scanner is modulating the radiation dose to achieve consistent image quality. And they work differently, they have different strategies. But because we can measure the outcome, we can say, okay, let's try to change the protocol on this scanner to be closer to the protocol on the other scanner, because at the end of the day, we want to keep to the patient the same quality of care. Also, what I was mentioning before, we can go towards something a little bit more patient or population specific. Again, let's talk about liver cancer, because I talked with the gastroenterologist about this. If we have specific ethnic groups that are more sensitive to liver cancer, and they also have a cirrhosis or they have other risk factors, perhaps we can design a protocol specific for this kind of situation. And then on the non-nerd side, on the visionary and fantasy world, I would like to see in the future some kind of shared decision making between practitioners, but also between practitioners and patients. Because patients are smarter than we think. Every once in a while I get ibuprofen because I have headache, or I run, I have bad knees pain, whatever. And then I go read on the ibuprofen drug fat and say can cause severe stomach bleeding, heart failure, that can be fatal. And people get ibuprofen. We do our own risk to benefit. Do I want the headache or do I want the risk of severe stomach bleeding? We do this. So I think that, again, this is like a vision, the fantasy world, whatever, but we can perhaps aim to the same approach also in radiology. where we can discuss with the patient and say, okay, this is the risk of not taking the exam. What do you want to do?
Dr. Francesco Ria is a medical physicist, once again, from Duke University. Dr. Ria, Francesco, thank you so much for joining us today on Rethink Imaging. It's been just delightful to have you here today.
Thank you, Chris. And I always follow your podcast. It is really a pleasure to be here.
Thank you so much.
Frame by Frame Rethink Imaging is brought to you by Imalogics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Imalogics is rethinking imaging in healthcare, visit imalogics.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Imalogics, thanks for tuning in.